and he's coming from Chicago. And thank you very much for coming.
I am a student at Northwestern in Chicago. I think the other word is right here. Okay. You still can't see it. But my background is in cognitive science, and when I went to medical school, I became interested in neurosurgery and how we could utilize plasticity in order to improve patient care. So I presented my thoughts to Dr. Matt Tate, who's in the audience today, and he supported my ideas, and we set out to find what would happen to patients with brain tumors and motor plasticity, and we did this using serial fMRI. Okay, so we believe that there are several mechanisms in which plasticity can occur. I'm showing this on the cellular level. So on the left, we have an example where if the neuron dies, the neighboring neurons can resume the function by sprouting terminal axon projections. On the right is an example of cortical redundancy, where one of the neurons inhibits a redundant pathway, and when that neuron gets injured, the redundant pathway can activate and assume the function. Moving to whole brain patterns, we believe from healthy adult subjects and from the stroke literature that there are primarily two major patterns of motor plasticity or motor recruitment. One, recruitment around the lesion, which we term ipsi-lesional recruitment, and recruitment on the anatomical analogous side on the other hemisphere, termed contral-lesional recruitment. In this image, the lesion is pictured in blue and cortical activity is pictured in green. So gliomas are an exciting model, but as many of you know, they're sometimes difficult to localize, and we can take advantage of their inherent heterogeneity in order to isolate factors that we want to study. So for example, we can look at a variety of different variables, such as age. We can look at growth rate, which was talked about before. We can look at size. We can look at location. And all these we can look at and how they can affect cortical recruitment. Additionally, gliomas tend to recur and need resection, so we can look at the effects of repeated injury as well as surgery and how that affects plasticity. So over the years, our understanding of how the brain reacts to primary brain tumors, insults, has grown. It started with observations that patients could have tumors in eloquent areas without functional deficits. This pointed to a theory that maybe the tumors were reorganizing cortical centers. And then the literature grew to look at where those reorganizations could occur. And recent evidence suggests that supplementary motor area could play a role as well as interhemispheric connections. So on to what our actual study looked at. We identified patients with 2 fMRIs with a surgery in between, and also that we were specifically interested in motor tasks, although we hope to expand that. And so they had to have motor tasks in both scans, and we were only concerned about primary brain tumors. So in total, our cohort consisted of 13 patients. The primary outcomes that we were looking at was ipsi-lesional recruitment, so recruitment around the lesion, and then contral-lesional recruitment. And we did that using a voxel-based ROI analysis. And we compared the amount of activity from the first scan to the second scan. So our patient population was fairly diverse. Our median age was about 50 years old. The time between each scan was a little over 1 year. As you can see, our patients tend to have higher grade tumors, although there were some low grade gliomas in there. And the distance from the primary motor cortex was about 4 centimeters. As far as clinical deficits, our patients were fairly diverse in this area. So on to the actual results. We conducted a group-level analysis of the different factors that might contribute to the different patterns of plasticity that I recently went over. Several of the factors that we looked at, in fact, did yield significant results. Just to note that positive numbers on this graph indicate greater levels of plasticity. So certain factors that were significantly associated with ipsi-lesional recruitment were things such as distance from the motor cortex, greater than 2 centimeters, things such as a smaller sized tumor, less than 16 centimeters cubed, low-grade pathology, and slower growing tumors. Conversely, we also found significant results for contral-lesional recruitment. Again, positive numbers indicates greater levels of recruitment. So here we can see that time between scans as well as age played a factor. So shorter time in between scans, less than 10 months, and patients greater than the age of 50 resulted in a significant contral-lesional pattern recruitment. And then also greater size of tumor and closer distance to the motor cortex. So this is a summary table. One thing I'd like to point out is just that while we believe that plasticity is induced in order to preserve function, when we did a group level analysis on the functional capacity of the patients, we didn't find any significant results. And so I presented a lot of data, and I want you to take away with 2 major points here. Okay, so my take-home points. 1, indolent, smaller tumors that are growing further away from the motor cortex tend to show an ipsi-lesional recruitment pattern, and larger, more aggressive tumors that are growing closer to the motor cortex tend to show a more contral-lesional pattern recruitment. So how can we put these ideas together? And I think that one of the mechanisms to explain this could come from non-human primate literature. It's been hypothesized that motor function comes from both hemispheres and that there are inhibitory fibers that run transcallosally to inhibit the ipsilateral side here. So I want you to imagine that you have a large tumor. This is my attempt at drawing. I want you to imagine a large tumor that's sitting close to the motor cortex. What we think happens is that both the cortical spinal tract and the inhibitory fibers get knocked out here, which will allow for I guess in this image, the ipsilateral side to resume some of that function and preserve the function of the patient. And then another step is if you can imagine that the tumor is further away, it's smaller. We believe that maybe the edema from the tumor or mass effect can cause an increased blood flow to the ipsilateral or the contralateral side without having to involve the other hemisphere. So some of the limitations of our study sample was smaller, so external validity and generalizability could be of concern. Additionally, it's a retrospective study. We couldn't control when we saw the patients, so the patients came in at different stages of their clinical care. For example, some patients may have had a surgery before they came to see us, or patients may have had tumors for a very large time with high disease burden. So I want to circle back and just talk about how I can see how this can be used for patient care. Number 1, I want you to take away that motor cortical plasticity is very common and it does occur, and that plasticity is an ongoing healing process that may take time. So we believe that over time, the brain is trying to reorganize its cortical centers and preserve function. We think that somewhere maybe around 10 months is when we see possible switch in cortical recruitment patterns that occur, and that when you follow your patients, perhaps using some of the modalities used in this study, such as serial fMRI, in order to individualize your intervention techniques may be appropriate. Lastly, I want to talk about this, a new field term, plasticity-induced rehabilitation using repetitive TMS. Large meta-analysis in this area have not revealed significant results in using repetitive TMS in order to recover motor function. This is primarily into the stroke literature. And I believe that one of the downfalls of these studies is that they use the same protocols for all patients. And I think that what our study really showed was that patient-level factors and tumor-level factors affect how the patients will reorganize their cortical centers. So not all patients are the same. And for example, if you have a patient with a large, fast-growing tumor, it may be that you need a protocol of excitatory stimulation to the contral-lesional side, whereas slow, smaller-growing tumors may require more inhibitory protocols. And I believe that individualized programs with patient-level factors in mind are the way forward and may target specific plasticity patterns and thus improve patient care overall and preserve function. So I want to thank you all for taking the time to listen to my talk, and I want to particularly thank Dr. Tate, who really helped me make this project my own and support me along the way. Thank you.